I recently came across this article at Archive Disease of Childhood, which is actually a national review of asthma deaths in UK, United Kingdom. And the article basically, as I acknowledged in my initial slide, is from Archive Disease from Carroll et al. And it is basically highlighting the way they did the survey and their findings and their recommendations. So, as I just mentioned to you, the National Review of Asthma Deaths recommended that a specialist review should be requested if there had been 3 or more courses of oral steroids, 2 or more visits to accident emergency, or an admission to hospital. This review reports the results of recent interviews, a study of 126 healthcare professionals. More than half of general practitioners reported adopting a higher threshold than this. General pediatricians set a higher bar still. Their median threshold for referral to a subspecialist asthma clinic were 4 courses of oral steroid, 3 hospital admissions, and 30 days off school in the previous year. So what they considered how people are practicing and looking after these asthma cases was the number of oral steroid courses people have used in 12 months, number of hospital admissions happened, and how many days these children were off school. Good indicator of how severe asthma is and also how much it affects children's day-to-day living. And this is probably covering a bit more of children and young adults, what they called as CYP in UK. Now, I think last year somebody introduced to me presenting something from GINA, which I heard first time last year, was Global Initiative for Asthma. And then while attending Pedicon this year in January in Indore, I think there were a couple of discussions and sessions about Global Initiative for Asthma. And the people presented were mostly respiratory physicians, pediatricians, I should say. Now, the GINA is not a guideline. That's something people should remember. It is evidence-based practice recommendations. So GINA document that individuals with so-called mild asthma are also at risk for poor outcomes. This is largely due to the adverse effects of regular use of short-acting beta agonist, which is being referred as SABA, and insufficient prescription or adherence to inhaled steroids, which has resulted in fundamental changes of international recommendations for treatment of asthma. I'm sure the people who are in the lecture now, they all are very well aware of GINA recommendations. Now, my aim was not to go into acute asthma management because this talk and this paper is basically more related to outpatient management and referrals to asthma clinic or respiratory physicians for further intervention rather than managing asthma as acute exacerbation of asthma either in emergency department or pediatric intensive care. Now, I think I did write something in my Nirmal group, academic group, a couple of weeks ago when one of our registrar presented management of severe asthma in a regional hospital and how we went ahead with transfer to this child to a tertiary care in Sydney. There was some thing which I thought has changed in guidelines or how people are managing asthma in Australian intensive care and regional hospitals. So the message as I summarized was that we use 20 minutes 3 SABAs, and then we go on to nebulized, continuous nebulized salbutamol. And then the question comes how you move ahead. We have been previously practicing using IV salbutamol. I'm very pleased that Tejas is online. and Nirmal is there. So I know they manage most of the pediatric intensive care. So the recommendations for us came is use 20 minutes salbutamol by spacer. And then if you are still think asthma is not managed, then you go with continuous salbutamol nebulizer, which is always to be used with oxygen. And then subsequently, we used to start IV salbutamol. Now, it seems that IV salbutamol has fallen out of favor. The problem being serious outcomes because of lactic acidosis. I'm more than happy for Tejas to add on now or whenever he wants to. There was a suggestion that magnesium sulfate has been used in asthma, acute asthma management, but in my practice, I have not seen much benefit. And there were suggestions that probably we are using too late. So now the suggestion is as soon as you go to nebulized, continuous one, you might give a loading dose of Max-Sulf. And then instead of running IV salbutamol, which I think depends on which intensive care you go to or who is advising you management in a regional hospital, there is still place for IV salbutamol, but the question was not keep on increasing the dose because it is not going to work if it has not worked in the appropriate doses. Now the shift is towards using Max-Sulf and IV aminophylline. And there is a recommendation that you can either use it as an infusion, particularly aminophylline infusion, or you can use 6-hourly boluses of aminophylline. Now we all know, particularly Dr. Jhala and Nirmal might remember, when we were training as postgraduates, we had only oral steroid or prednisolone and aminophylline. We didn't have salbutamol or beta-2 agonist at that time. So that time has come back, and that was given up because of narrow therapeutic index. And that still continues to be a problem, that when you use IV infusion of aminophylline, you're looking at narrow therapeutic index, and you might need to monitor it with drug levels, which is probably hard. And even in my hospital, local hospital, regional hospital, we can't do these things. So I think I'll leave acute asthma management there because that was just to touch bases about acute asthma. Now, what is severe asthma? Part of problem that exists is that there is a variation in the definition of severe asthma, which is currently defined retrospectively based on the amount of treatment required to maintain control. So we all remember that we used to call infrequent asthma, seasonal asthma, chronic persistent asthma. So where you put severe asthma, is it more of chronic persistent asthma where it flares up and get into severe asthma, or it is infrequent asthma or seasonal asthma which deteriorates very rapidly and presents as severe asthma. As I earlier mentioned about CYP is children and young person, which includes children and even young person up to 18 to 21. With poor symptom control despite being prescribed high dose asthma medication, do not always have severe asthma. Some have alternate diagnosis and others will have modifiable factors such as non-adherence. These individuals have difficult asthma. Difficult asthma is at least twice as common as severe asthma. So I'm learning that terminology with seizures also, that it used to be intractable seizures or just epilepsy or seizure. And now people are writing as difficult to control seizures and then intractable seizures. So they are finding something before saying that you are towards the end of the spectrum. There is something which is moving towards end of the spectrum or can move towards the other side. While severe asthma currently accounts for up to 50% of asthma-related healthcare costs, the treatment landscape for SIP with severe asthma is changing as newer drugs become available. So what they were talking about, most of the adult asthma deaths are mild to moderate asthma, whereas most of the children are on the severe asthma spectrum. Now, this slide has probably not come up well. This is basically a similar table which shows how general practitioner pediatricians, when they decided to refer to respiratory clinic. Now, I think you might be aware that the health system in Australia, UK, Canada is different than what we see in India and US. The major difference has been, for old timer, we remember we used to have a lot of general practitioners with MBBS qualification and training, and then the specialist. I think we have moved towards more trend of pediatricians directly seeing children rather than going through general practitioner. So these data and studies, what I am presenting is more related to the tier system where patient first has to go to general practitioner and he manages or she manages that. And if they can't, then they refer to the pediatrician. Patients in acute stage have a choice to go to the general practitioner or go to the accident and emergency department and being looked after by either accident emergency staff or pediatrician, pediatric registrar or pediatric consultant, whoever is on call. So what they basically said is probably people are treating too long before realizing that it needs more evaluation and escalation of treatment. And as I don't know whether you can read it, but basically it says even the general pediatrician waited for 4 attacks to take place in a year and 4 courses of oral steroids and at least 3 A&E attendance and 3 hospital admissions and at least a month of off school in a year before considering a referral to a child get more evaluated with asthma. Now, who do we call severe asthma? So it is definitely, it has to be with optimized treatment where you have made sure that the technique is correct and also that apart from technique, the medications are taken properly. So compliance and technique both are extremely important. But this talk is a bit over that you have ensured that there is a good technique and there is a good compliance. And still there are ongoing problems with management of asthma. So this basically causes higher doses inhaled steroids, more than 800 microgram beclomethasone, equivalent daily for children under 12. So 6 to 12 if we are using more than 800 microgram daily, or more than 1600 gram equivalent daily for children more than 12 years. So that's one is called, despite that if you are not able to manage, then it would be classified into category of severe asthma. As I said, adherence and inhaler technique needs to be checked and verified before you move forward from there. And along with that, there are uncontrolled symptoms, which is being assessed by Childhood Asthma Control Test. This is CACT for children from 4 to 11, and Asthma Control Test for children more than 12. These are asthma controlled questionnaire or similar could be used. Or asthma attacks, more than 2 courses of oral corticosteroids for 3 or more days in the last 12 months. Any hospital admission for asthma attack in last 12 months. So you can see where we are moving into with the definition of severe asthma, that even 2 oral corticosteroids courses in 12 months, even any hospital admission, any previous pediatric intensive care requiring ventilation. So even one previous PICU puts them on the severe asthma spectrum. The definition is based on combination of Global Initiative for Asthma Guidelines, Scottish Intercollegiate for treatment of asthma. So that's where this definition has come from. Now, the questions have been asked is when to refer to specialist care, red flags for referral. Now, I'm not here talking about pediatrician. Probably we are talking about more towards the respiratory physician, pediatricians, or asthma specialist or clinics, which I think are coming up in India. And as I said in the Pedicon, there were a couple of people who were presenting this global initiative for asthma management in India. And that was, I think most of them, Nirmal might be able to add to that, but I think they were mostly the respiratory pediatricians who were dealing with the pulmonologists, they call themselves. So any child presenting to secondary care with diagnosis of severe difficult to treat asthma, who has more than 2 courses of oral corticosteroids for 3 or more days in the last 12 months, had more than 1 hospital admission, inpatient A&E in the last 12 months, ever had a PICU admission requiring ventilator support, or persistent poor control or unclear diagnosis for more than 3 months, has a requirement for long-term, more than 1 month of oral corticosteroid maintenance therapy. I don't think I had any child whom I have treated on oral corticosteroid maintenance therapy so far. I'm not sure if anyone present now has done so, or has other factors that increased risk for death from asthma. For example, IgE-mediated food allergy anaphylaxis, heavy use of short-acting beta-2 agonist, that is more than 1 canister per 200 doses per month, adverse behavior or psychological factors. So as you all know, now the MDIs or meter dose inhalators have come with a counter. So people know how much is being used, and particularly when it finishes, because before you could just shake it and feel that you still have the medication, but you didn't know whether the medications are already exhausted in your either beta agonist or even in the corticosteroid one. Proposed requirement for children and young people severe asthma service, a specialist multidisciplinary pediatric asthma service that has at least 2 respiratory pediatricians with specific asthma training and expertise, asthma nurses, and direct access to the other specialty services such as flexible bronchoscopy, lung function lab with certified spirometry specialist, lung physiology, physiotherapy, pharmacist, clinical psychologist, mental health services, social worker, ear, nose, throat specialist, and speech and language therapy. So they propose that at least people where we are going to refer these children as a general pediatrician, they should have at least these kind of facilities available there, and they can basically assess them more. Now, this is a flow chart, what has been proposed in this article. And as you can see that, can you read on this slide?
सर पढ़ा जा रहा है लेकिन थोड़ा मुश्किल से आ रहा है, अदरवाइज तो थोड़ा ध्यान से देखना पड़ेगा ऐसा.
So basically, I'll just read from this one. So it says child presents with uncontrolled asthma symptoms or asthma attack. Has the asthma diagnosis has been confirmed? If no, then confirm the diagnosis. If yes, then has their adherence and inhaler technique has been checked? All inhalers and devices like spacer should be rightly used with the dose and one. ICS inhalers collected and used, and no evidence of SABA overuse. So I think this paper has been also emphasizing about overuse of short-acting beta agonist. And I think GINA's main message was not to use short-acting beta agonist by themselves, even for infrequent asthma. So if they say if that's not correct, then you educate. Otherwise, you move to the next step, which is their treatment optimized? So medium to high dose ICS, which we talked about, and using a long-acting beta agonist plus minus leukotriene antagonist. Now, I think I just wanted to mention for maybe relatively younger people around, I think it was 80s or somewhere, yeah, I think 80s when first time there was flash news in the newspaper, we found a cure for asthma. And that was for the news for montelukast or leukotriene antagonist. People were very excited that they found the cure, but it became one of the adjunct of treatment rather than trying to fix all asthma problems. So if you have done that, if you have not done, then you optimize the treatment. And if you think, yes, you have done that, then as we discussed about uncontrolled symptom more than 3 months, as assessed by questionnaire, and then the question of referral comes. If the asthma attacks more than 2 courses of oral steroid, I think we have gone through, then you can refer them, or there are other red flags, then you can refer them. Now, as far as medications are concerned, in GINA recommendations, children over 12 years, salbutamol or formoterol with ICS for asthma. You can use, or you can add tiotropium once daily, which is similar to ipratropium, atrovent, immunotherapy, prednisolone or low dose azithromycin, 10 milligram per kilo 3 days a week for 8 weeks, or oxythromycin 150 milligram daily for 8 weeks. Biological after phenotyping. For children 6 to 11 years, it is short-acting beta agonist with inhaled corticosteroids or long-acting beta agonist and inhaled corticosteroids. Under 5, inhaled corticosteroid, if you really need to, you can double the dose, or you can use 3 times daily in severe asthma. So we normally don't use more than twice inhaled steroid, but they were recommended that either you can double the dose or you can even give it 3 times. So these were some recommendations from GINA 2019. So going to the checklist, confirm the diagnosis, consider the differential diagnosis, look for the factors, inhaler technique, suboptimal adherence. I think in India, a bit more difficult to check on with the chemist whether the people have filled up scripts because many of these drugs still they can get without a script. So here they are restricted. So chemist can provide you the information, how many repeats the patient has taken, and you can look at the adherence or the compliance. Comorbidities like gastroesophageal reflux, chronic rhinosinusitis, and obstructive sleep apnea. Modifiable factors like smoking, allergen exposure, and medications like beta blockers and NSAID, which we don't use much in children. Overuse of short-acting beta agonist, and then not to forget anxiety, depression, social difficulties. So optimized management is asthma education, exercise helps, weight loss, particularly many of these children are obese, stop smoking, which we don't see much in children, but still even passive smoking is bad, and flu vaccination. Optimizing treatment, treating comorbidities, long-acting beta agonist, tiotropium, and leukotriene receptor antagonists. Now, this is a part which probably we might run through because I know it's not the real scope for general pediatricians to work with, but being aware of what can be done or what is available if you decide to refer these children to respiratory clinicians. Now, I think it's a very simple question. What are the markers for inflammation in respiratory or airway? And basically there are 3 markers which people talk about is blood eosinophil, sputum eosinophil, and FeNO. Now, FeNO is fractional expiratory nitric oxide, which basically reflects inflammation in your airways. It's also used for children with different respiratory problems. And I think most of the specialized clinics have them. So what they are talking about type 2 airway inflammation is what they initially mentioned about the severe asthma phenotype, that if blood eosinophils are more than 150 or fractional exhaled nitric oxide is more than 20 ppb. So I was reading somewhere that normal level of exhaled nitric oxide in children is less than 20. 20 to 35 is towards mild to moderate, and more than 35 is severe. Or sputum eosinophils, we rarely do that, but that's again a good indicator of what's going on in your airways. And if it is more than 2%, then it is significant. Or asthma is clinically allergy driven, or need for maintenance of oral corticosteroid. Now, when we say allergy driven, it's mainly meaning people who are atopic, and whether they have severe atopic dermatitis or rhinosinusitis or severe food allergies, they all will come in this group. What they suggest is investigate for comorbidities and differential diagnosis. And the tests recommended are full blood count, CRP, immunoglobulin levels like IgG, IgA, IgM, IgE, fungal precipitants, chest X-ray, CT, HRCT, and DLCO, which is a carbon diffusion study. Skin prick test, or IG for specific allergens, if we are aware of. ANCA, CT sinus, PNP, echocardiogram. So this is basically going towards a severe asthma. Is it really asthma, or there is something else causing it? If yes, then adherence test, increase ICS dose for 3 to 6 months. Consider AERD, which is anti-reflux treatment, ABPA, which is allergic aspergillosis, nasal polyposis, and atopic dermatitis. If not, then we go with tiotropium, or add, as we said, doxycycline, which is Rolide, or azithromycin, and low-dose corticosteroids. What treatments are available for type 2 inflammation? And it is anti-IG therapy. So which are the patients which are eligible for anti-IG therapy, which have got a severe allergic asthma, have got a skin prick test positive, they've got quite high levels of IgE, and they had exacerbation in last year. Who gets good response? Those with blood eosinophil more than 260, fractional exhaled nitric oxide more than 20 ppb, allergen-driven symptoms, and childhood asthma. So if you look at, I'm going to go through more 2 or 3 of the different biological treatment, but it seems that for childhood asthma, which is allergic-driven, anti-IG therapy is probably the best option. The other 2 are anti-interleukin. So anti-interleukin 5 or anti-interleukin 5R, which have come market names of benralizumab, mepolizumab, and racilizumab. Indications: blood eosinophil more than 300, so more allergic, exacerbation in last year. Who gets a good response? There's a high blood eosinophil, no exacerbation in previous year, adult onset asthma. So this is more useful for the people who develop asthma as an adult rather than as a child, and nasal polyposis. The other third one, which is anti-interleukin 4R, which is dupilumab. I think Ravi spoke to being used for atopic dermatitis. So indication, blood eosinophil more than 150, fractional expiratory exhaled nitric oxide more than 25 ppb, or need of maintenance for oral corticosteroid. Who gets good response? High blood eosinophil, high fractional expiratory exhaled nitric oxide, nasal polyposis, always used to treat moderate to severe atopic dermatitis. So if you're dealing with severe atopic dermatitis, this is probably one of the interleukin which might be helpful. Advice for referring teams. So when you decide to refer, when referring to a specialist multidisciplinary team, it is useful to include as much as information about the child and any test results of the treatment they may have received as possible. This can include data for confirmed asthma diagnosis, confirmation of adherence and inhaler techniques, current treatment and doses, copies of records of all asthma prescriptions issued in the previous 12 months, results from any tests performed, for example, lung function spirometry, best annual peak expiratory flow rate, fractional excretion of nitric oxide, screen pricked or serum eosinophil count, any social safeguarding concerns such as not being brought for review in practice or to the hospital, or family history that should be taken into consideration, and any comorbidities that are present. It could also involve relevant historic medication prescribed, printouts, previous hospital admissions and correspondence, relating to the family carer belief systems, relating to asthma and to the medication use. So I think most of the people, as we talked about atopic dermatitis or eczema management, people are too scared of side effects from inhaled corticosteroid or corticosteroid, and discontinuation of treatment or reluctancy to give it is always there. And again, you need a lot of time to talk to this family to explain proper technique and compliance being checked out from time to time. To conclude, all too often asthma attacks in children are treated as isolated acute incidents by a variety of different healthcare professionals in different settings, including pediatric emergency department and out-of-hours services. Referral to specialist multidisciplinary care recognizes and addresses the chronic nature of the disease and ensures the consistency of care that these children deserve. Conflicting guidelines and a lack of clear referral pathways for children and young person with severe asthma mean we are destined to repeat our failures. So I think that's in a nutshell what I wanted to speak. And as I mentioned that probably it is more question of rechecking and looking at differential diagnosis and keeping in mind that there may be some of these patients who have more severe variety of